Hello, can you hear me? Hello, can you all hear me? Okay, is my voice clear? Okay, so shall we start the class? Fine, I'm Dr. Sushma. I'm working as assistant professor in Oxford Medical College, Bangalore. Okay, I know you all are preparing for entrance exams and pharmacology is very, very important subject. Lot of stuff about drugs. So if you don't know the concept, it is not easy to solve the MCQs what is asked in NEET exam these days. Okay, so we will see a lot of concepts and we will go topic wise. We will spend enough time on the content and we will also solve the related MCQs. Few MCQs we will discuss. All types of MCQs will be included here. And once the topic is covered, you can cover more MCQs and you can get back to me if you have any doubts. Is that clear? Is that fine? Okay, to start with, in pharmacology, we always go with general pharmacology because in systemic pharmacology, to know about every drug, we need to have a sound background of its properties, which is dealt in general pharmacology. Okay, so we will go lot of concepts here to learn in this topic, which makes you to understand better about drugs and systemic pharmacology. Clear? So general pharmacology basically deals about what exactly is a drug, how does it produce a particular effect in the human body. Say for example, you take paracetamol for headache. How does it relieve the headache? What all does it do when it goes through the body? And also what happens to the drug when it is going through the body? What are all the changes that happens to this particular drug? And finally, how is it excreted? All these things are seen in general pharmacology. Okay. Is my voice clear and audible? Are you all able to see the slide? Okay. So we'll just I will just brief you about the basic things in pharmacology, which may or may not be important for you. Okay, but it's always better to go from the basics. Clear? So we will just see what is pharmacology. So pharmacology is a branch which deals with everything about drug. Very simple. Okay, so it deals with the study of drugs and its interaction with the living system. So how does it interact with the human body? How does it relieve the headache? Or how does it help to reduce your pain? Okay, so the effects of drugs and its interaction with the living systems is what is called pharmacology. So it's a branch, it just basically deals with the drugs. So here, mind you, the word drug doesn't mean the drugs of abuse only. Drug means any medicine. Any medicine is called a drug. Clear? Now this word was actually derived from two words called pharmakon, which means active principle. See, earlier we used to prepare drugs from plant products or animal products. Most important was plant products. So in the plant product, say they obtain a particular product from a tree, that the entire product would not be used. The active principle would be derived from that particular product, which was used as medicine. So that is called pharmakon. So pharmakon is active principle present in the medicine, and logos is to discourse, to give medicine, to give the active principle. So that is called pharmacology. So till here, is it clear for you? Fine. So few points about the people behind starting this branch of pharmacology you should know. This is asked in quite a lot of entrance exams. This is a very, very easy thing, but if you don't know, you will miss the entire mark. Okay, so few things which are important you need to know. Who was the first person to start the first laboratory of pharmacology? He's Rudolf Buschim. Please remember this. He was the first person to start a lab for pharmacology. But the father of pharmacology is popularly called Oswald Schmidberg. Oswald Schmidberg is a person who is actually called father of pharmacology, but grandfather of pharmacology is called Paracelsus, which means much before this Oswald Schmidberg carried out his work, a lot was done by Paracelsus, but he did not know how to put across in front of the world. Okay, but he had given a lot of contribution to the world of pharmacology by deriving quite a few drugs from plant products. Hence, Paracelsus is called grandfather of pharmacology, and Oswald Schmidberg is called father of pharmacology. And the next most important person you all would have read in microbiology, that is Paul Ehrlich. We all have Paul's Ehrlich's principles and all that. So Paul Ehrlich is called father of chemotherapy because he discovered a lot of antibiotics. Clear? So I just repeat, Rudolf Buscemi was the first person to start the laboratory for pharmacology. Paracelsus is called grandfather of pharmacology. Oswald Schmidberg is called father of pharmacology. And Paul Ehrlich is the father of chemotherapy. Is this clear for you? Okay. Then we have few definitions which may be asked here and there, but we won't, let us not spend too much time on that. But if these, they're not many times asked because there's just straight away definitions. What is asked in pharmacology is usually either a new drug or a clinical based question. They give a clinical scenario to you. Either you have to diagnose and then come out with the treatment, or they'll ask questions about the drug. Okay, but if at all these direct questions are asked, you are not supposed to miss answering this because they're very, very easy. So we will just go through these definitions. Fine. First thing is pharmacognosy. Pharmacognosy is actually a part of pharmacy. It doesn't come under pharmacology, but still we will see pharmacognosy means it's science of identification of drugs from natural sources. It could be a plant product, it could be an animal product, it could be from a mineral like calcium, iron, gold salts, etc. So anything from natural source identification is called pharmacognosy. Okay, then we have pharmacoeconomics. Economics is all to do with cost of drugs, money, right? So pharmacoeconomics means it's analysis of cost of drug therapy to the healthcare system and the society. How much of cost is going towards drug therapy by the healthcare system and the society comes under pharmacoeconomics. It's a very simple definition. Then pharmacoepidemiology. Epidemiology is nothing but study of anything in a population. So, okay, epidemiology is study of anything. It could be, I want to assess what's the incidence of particular disease in a population. I want to see what's the incidence of breast cancer in a particular population, etc. That is called epidemiology, study in a population. Pharmacoepidemiology means study of the effect of drug in a population, in a group of people, set of people. Okay, then we come to pharmacovigilance. Vigilance is to be watchful, is to be alert. So what is that thing that we have to be alert about a drug is its side effects or adverse effects. So it is a branch which is dealing with everything about the adverse effect, that is detection, evaluation, understanding why is this particular adverse effect happening, and prevention of further such adverse events or any other drug related problems. Other than the pharmacological effect, the drug can have adverse effect. So that we have to know why is it happening. We have to detect first of all that it's an adverse effect, and we have to prevent future such occurrences of adverse effects. That is called pharmacovigilance. Clear? And then we have pharmacogenetics. So pharmacogenetics means what? Sorry. Now, genetics is a branch which deals with what is the effect of anything on the genes. Now, for example, there can be two individuals, one who is allergic to penicillin, one who is not allergic to penicillin. Now, why this individual is allergic and not the other one? We have no answer. It may be genetically mediated. So, this kind of any genetically mediated variation in the drug metabolism and response in human beings is called pharmacogenetics. What is the effect of the genes in the effect of on the effect of drugs is called pharmacogenetics. Okay, then we have a similar one called genomics. Now, what are we doing by making use of this information? Now, I do a study. I know this particular gene is producing effect on one particular drug. Now, what are we doing? So the use of this genetic information to guide the choice of drug and the particular dose on an individual basis. Like, for example, I know people with this genetic defect are allergic to penicillin. So if I have this genetic information, it helps me to choose the drug in that particular individual. So I would not administer the same penicillin or any other drug for that matter in people who have the same genetic issue. So it is helping me to guide this genetic information for the choice of drug and also the dose. What is the dose that is causing adverse effect? What is the dose that is safe on an individual basis? Okay, these are few definitions. Are this clear for you? You just have to give one reading about this. Right. Then we have something called pharmacopoeia. These are all books which contain information about the drugs. It's very, very simple. We have two things. One is pharmacopoeia, other one is formulary. Okay. Pharmacopoeia contains every detail including physical and chemical properties of a drug. Whereas formulary contains what is relevant for a clinician. Like for example, I am not very interested in knowing what are the physical properties, it reacts with what are the chemical properties, how was it prepared. I am not very interested. I want to know the clinical properties of the particular drug, which means what is the dose that is to be given, what is the indication of it, what is its bioavailability, I mean how much of it is entering the systemic circulation, what is its clearance, what is its T half, so what is the frequency of administration, and what are its adverse effects. So clinically relevant information will be present in formulary, and everything about physical and chemical properties will be present in pharmacopoeia. This is the basic difference. Clear? Now formulary is most important for us. We have many formulary. So Indian formulary is called NFI, National Formulary of India. That is what we all refer. Okay. We also have British formulary and US formulary, etc. We follow NFI. Clear? So these are two things. Then we have something called essential drugs and orphan drugs. Essential drugs means the most essential drugs. I don't call an anti-cancer drug as an essential drug. I call paracetamol as an essential drug. I call analgesic as an essential drug. So drugs that satisfy the priority healthcare needs of the population. Okay, so priority healthcare, which means some respiratory infection, some diarrheal disease, some constipation. So the most priority healthcare needs of the population, these drugs which satisfy are called essential drugs. See, cancer may or may not be common. All this while it was not common, of course, now it has become common, yet we don't call anti-cancer drugs essential drugs. Day in and day out for treatment of the most common conditions, what we use are called essential drugs. Then we have orphan drugs. These are the drugs which are used to either treat or for diagnosing or for prevention of rare diseases. Orphan is rare. Orphan drugs are used for treatment of orphan diseases or rare diseases. Or we also give orphan drugs, we also give the name orphan drug to some drugs where it may be used for a common disease, but there is no expectation that the cost which is put forth for making the drug will be recovered from the sales of that drug, which means which is not very commonly marketed. It is not very commonly used. That is called an orphan drug. Clear? Are these definitions clear for you? I don't want to spend in too much time on these things. These are quite easy. Fine. Is it clear? Can I move on to the next slide? Okay, coming to a small and brief topic, source of drugs. So where all drugs are derived from. As I already mentioned, one is natural source. So natural can be from plants, animals, or microorganisms, or even the native minerals that are available. Those drugs which are derived from plants are basically called alkaloids. Okay, most popular examples for that are morphine. Morphine, you all know it is derived from the opium. It's an opioid analgesic, Papaver somniferum. Okay, atropine is also an alkaloid which is derived from the tree Atropa belladonna. Digoxin is also an alkaloid which is derived from the tree Digitalis purpura and Digitalis lanata. Digoxin is also called Digitalis. So those which are derived from the plants are called alkaloids. We also have animal preparations. Like for example, insulin. Insulin is used to treat diabetes. But where did we initially synthesize insulin from? It was from beef and pork. Of course, now we follow DNA recombinant technology, but earlier it was produced from animals. We also have heparin. Heparin is an anticoagulant which was actually derived from liver. Then you have thyroid hormones. Thyroid hormones we all have. If you have to synthesize it exogenously to administer for somebody. It's derived from animal. Or you have microorganisms. There are bacteria or fungi from which we derive certain drugs. These are called antibiotics. You all know about it. Antibiotics are actually derived from a microorganism. And minerals, as I told you, whatever calcium, iron, magnesium salts, whatever we are prescribing, they are derived from the minerals, including radioactive isotopes like iodine. Clear? These are natural sources. But if you come to synthetic means we are preparing with the help of DNA recombinant or genetic recombinant technology. Nowadays, what I told you, insulin is coming from DNA recombinant technology because we cannot kill so many animals to produce insulin in millions of quantities. And we also have erythropoietin. Erythropoietin is actually a hormone which is secreted from the kidney. But if I have to give erythropoietin to somebody, from where shall I synthesize? So I use DNA recombinant technology to produce this erythropoietin to administer for individuals. So synthetic is basically by using DNA recombinant technology. Then we have something called hybridoma technique. So these are some newer drugs called monoclonal antibodies, which means we are cloning a single antigen and producing antibodies. Okay, this we will see a little later. That's the technique that is used for this is hybridoma technique. So we have natural, synthetic, and the drugs which are produced by hybridoma technique, which is called monoclonal antibodies. Till here, is it clear for you? Okay, I may go breathless here and there. Okay, so if I'm fast, you can just let me know. Now coming to the routes of drug administration. So what are all the different, once you take a tablet, some other time you take a syrup, some other time you go for injection, sometimes you go for enema, sometimes you go for IV or IM injection. It all depends, isn't it? So the basically routes of drug administration will be divided into enteral, parenteral, and topical. So enteral means, enteron means intestine. So enteral means it is entering the intestine, either through the mouth or through the rectum. It is entering the GI tract. That is called enteral. Parenteral is anything other than the intestine. It is not reaching the intestine, but it is somehow reaching the circulation, reaching the body. Then you have topical. Topical, you're just applying on the outer surface of the skin. So broadly, we divide into enteral, parenteral, and topical. Clear? So this is how we basically divide the different routes of drug administration. Under each, we still have further types. Like enteral, we have, it could be oral, or it could be rectal, or it could be sublingual, all of which will be entering the intestine. Parenteral, if you see, the routes which are not touching the intestine, like for example, all types of injections. It could be intravenous, intramuscular, subcutaneous, intradermal, intraarticular, that is into the bone. It is reaching the systemic circulation, but it is not reaching the intestine. Then we have topical, that is, it is applied externally on the skin surface. So because this is a very simple topic, I will not go in details into this. I have only included those standard questions that is asked from this chapter. Okay, nobody will ask you advantages or disadvantages of each route, that you all must be aware of. So what questions usually come is, this particular drug can be given by all routes except, or this drug is highly contraindicated by this route. Such questions. Okay. So which are the common drugs which are given by rectal route? We give paracetamol in case of high fever in children. We give rectal paracetamol because it is faster acting than oral paracetamol, because rectum has very high blood supply. Okay, that is one. And in case the child is not able to eat or drink anything, you can give by rectal route. The other drug is diazepam. Diazepam is a benzodiazepine, which is an anticonvulsant, and it has many other properties. So for a child with seizures, we give diazepam by rectal route. So these are some of the common drugs which are given by rectal route. Please give me 2 minutes. Yeah, come back. Am I audible? Can you all hear me? Then we go for some drugs which are given by inhalational route. Okay, so there's a difference between nasal and inhalation. Nasal is you're just putting into the nose. Inhalational is you're inhaling so that the drug reaches the lungs. Okay, I hope the difference is clear. So drugs which are given by inhalational route, you all know that it has to enter the lungs. Most common, you all know that, or we give oxygen, we give general anesthetics. All general anesthetics are given by, most of the general anesthetics are given by inhalational route. Like for example, we have popular examples, nitrous oxide, ether and halothane. And why have I put insulin here was, till recently, insulin was being tried. A lot of research was being done to develop inhalational insulin in the form of an inhaler so that the patient need not prick every day. But it's a failure. Okay, the research could not be progressed because insulin could not produce its effects when given by inhalational route. But definitely this question can be asked. Insulin was being tried by inhalational route. Please remember this. Then we have drugs which are given as transdermal patches. Okay, we get a patch with the drug which is applied on the skin so that the drug is released slowly into the circulation. Okay, the most common, you all must be knowing, we have for smoking cessation, we have nicotine patch. Okay, so smokers, smoking abusers, the same effect they obtain from nicotine instead of direct smoking. So as part of rehabilitation or to stop the de-addiction of smoking, we give nicotine patches. We also have nitroglycerin patches for angina, but of course we don't use as much because angina is an emergency condition where you need to give either sublingual or IV nitroglycerin. Should I increase the volume? Now is it okay? Yeah, okay. Fine. Then we have other drugs which are also given by transdermal patch route, like we have hyoscine. Hyoscine transdermal is available for people who have motion sickness. Say before they start traveling, 1 hour before the travel, we apply hyoscine patch so that the drug is released slowly into the systemic circulation. And by the time they start their travel, hyoscine would have produced its effect so that the motion sickness is controlled. And we also have fentanyl, which is an opioid analgesic, like morphine. But because of lot of adverse effects of morphine, we try to avoid as much as possible. So in place, we can use fentanyl, which is also available as a patch. Opioids we don't use for regular pain. So either it is a AIDS patient or severe cancer associated pain, then we go for opioid analgesics, or post-operative pain. Then we have clonidine as antihypertensive drug, and we also have bupropion, which is also used for smoking cessation like nicotine. So these are some of the popular examples of drugs which are given by transdermal patch. Please know nicotine, nitroglycerin and hyoscine, which are more commonly used. Then we have nasal. As I've already explained to you, nasal we administer into the nose. Inhalation, it goes into the lungs. So nasal, we have drugs like sodium chromoglycate, which is used for asthma. We get these nasal sprays, which is going through. Of course, definitely part of it may enter the lungs by inhaling. It doesn't mean that these drugs should not enter the lungs, but we are just using it as a nasal spray or a nasal drop. Okay, then we have drugs which are given by sublingual route. Just now I mentioned to you nitroglycerin is given by sublingual route for an angina patient so that it produces a faster effect in relieving the pain. We also have nifedipine, which is an antihypertensive drug. For patients with very high blood pressure, we give nifedipine to bring about immediate control of blood pressure. So drugs which are given by sublingual route, we have nitroglycerin and nifedipine. Fine. These are some of the standard examples of drugs given by different routes. Of course, there may be many others. Okay. Please go through. These are the questions that have been asked. And intradermal. Intradermal is derma is skin, into the layers of the skin. You all must be aware that you all must have taken a BCG vaccine on your left deltoid muscle, left arm. So that was given by intradermal route. That means we keep the syringe parallel to the layer of the skin, parallel to the surface of the skin, and we just inject a very little amount of the drug into the layers of the skin. We don't go deeper at all. And if at all I need to check sensitivity of any drug, like I give a test dose before giving the main dose because of the fear of anaphylaxis, I use intradermal route. So these two are the drugs, or these two are the situations where we choose intradermal route. BCG vaccination sensitivity testing. Then subcutaneous most popular ones, you all know that it is insulin. Insulin is given by subcutaneous route routinely. The other route which is given in emergencies is intravenous. That's it. We don't choose any other route for insulin. So for everyday treatment, we ask the patient to take subcutaneously, otherwise IV. Then we have heparin also. Heparin is an anticoagulant which is given routinely by subcutaneous route. Emergencies, we give IV route. We also have adrenaline, which can be given by subcutaneous route. So insulin, heparin, and adrenaline are given by subcutaneous route. Then intramuscular, IM is one of the most common route for giving injections. You all must be knowing, and you must have taken at least once in your lifetime. Analgesic, any antibiotic, many we give by intramuscular route. Then we have intra-articular, which means articular is a joint cavity, which means injecting a drug into the joint space. Like for example, patients with arthritis, it is not easy to treat because it could be age-related or it could be damage of the joint surfaces. So I cannot keep giving an analgesic for a long time for this patient's arthritis. So I inject steroid into the joint space so that his pain is relieved for next 1 to 2 years. Clear? So that's intra-articular. Then intra-arterial. Intra-arterial is into the artery. You might not have seen this kind of a technique. Intravenous is we choose the vein. Intra-arterial is into the artery, which is very deep inside. It's a very difficult procedure actually. So we only use in 2 conditions. If at all I have to do any angiogram, so I want to visualize the blood vessels, I inject dye into the artery, which means it's much deep. Arteries are located very deep. Veins are very superficial. I keep palpating for the pulse of that particular artery, and then I inject. It's a very, very difficult technique. Or for anti-cancer drugs, I use this route, intra-arterial. Then we have intracardiac, that is directly into the heart. I don't know how much of you would remember your second year pharmacology. There's no drug which is given intracardiac. Can you imagine? It's a very difficult thing. But in cardiac arrest patients, as a last resort, we try giving intracardiac adrenaline so that heart is again stimulated and heart starts pumping. But nowadays we don't follow this. It's a very blind technique. Okay, we have only practiced on cadavers. Earlier they used to do because it's a very blind technique. Very, because we have defibrillators and all that to try to revive the patient. So as a last resort, you can just try, and that's the only drug which is given by intracardiac, directly injecting drug into the heart by puncturing the ribs and directly injecting the heart. It was a last resort in cardiac arrest patient. Now it is no more practiced. So then few more points in this topic. So you should know this. Drugs which are given by only IV route, I cannot give by any other route. Okay, of course, blood transfusion, you all know blood transfusion is given only by IV route. And emergency drugs like dopamine, adenosine, which is an antiarrhythmic drug, esmolol, which is a beta blocker, which is actually given for hypertensive emergencies, and plasma expanders, which includes your fluids, IV fluids. You all must have seen any patient who's admitted in the hospital normally. So for example, if he has dehydration, will receive an IV fluid, and the IV fluid has to go through the vein and not anywhere else. So these are some of the drugs and products which are given only by IV route. And there are drugs which can never be given by IM route. That's very, very important. Please note this. So all the drugs are given by IV route except, okay, somewhere they can include phenytoin or heparin. So that will be the answer. So these drugs can never be given by IM route. 3 important things. Heparin, I just mentioned to you about heparin. It is given by subcutaneous route. And in emergencies, we choose IV route. It can never be given by IM route because these drugs will produce hematoma in the muscle or you cannot predict their absorption. Clear? How it is absorbed into the systemic circulation, you cannot predict. Either it is too high or too low. And you also have diazepam. Diazepam, which is a benzodiazepine, can be given by, it's generally given by oral route or at the most IV. It's never given by IM route. Even phenytoin, which is an anti-epileptic, should never be given by IM route because all these drugs will result in muscle hematomas. And drugs which are given through endotracheal tube. See, what is this endotracheal tube? It is a ET tube, is the one which connects the patient's lungs to the ventilator. Okay, so say the patient is in coma, who's connected to the ventilator, and I need to give some drug. If it's not possible for me to give by IV route, I can also give through ET tube. That is two important emergency drugs, adrenaline and atropine. Clear? Drugs which are given by ET tube are adrenaline and atropine. So is this clear for you till here? We are in the very, very, very basics. Okay, coming to the last part of this drug delivery system or routes of drug administration. Till now we saw IM, IV, oral, topical, etc. Now we have some special drug delivery systems. Okay, special forms of drug delivery. Like for example, about transdermal patch, similar or little higher versions of that. We have something called OcuCert. OcuCert. Cert is an insert. Ocu is eye. It's an insert which is put in the eye. For example, pilocarpine. We have pilocarpine OcuCert. It is just an insert which is just placed under the eyelid, and this drug remains around the clock and it acts for 7 days. Like for example, a post-glaucoma patient or post-operative patient, instead of instilling the drops every 1 hour, I just have to place this under the eyelid where it produces continuous effect for 7 days. That is called OcuCert. Then we have ProgestaCert. ProgestaCert is a progesterone insert which is inserted into the uterus. So it's basically an IUCD, that is intrauterine contraceptive device, which is put into the uterus, which is also impregnated with progesterone, and it produces a drug for 1 year so that the lady need not take an oral contraceptive pill every day, or she need not go for injections every week. So this is once inserted, it produces its effect for 1 year and she can forget using any other contraceptive. Clear? And then we have something called drug-eluting stents. Drug-eluting stents means these are stents which also release drug into the circulation. Okay, they are just stents, but they're backed up with drug. The stent is placed, but it also releases the drug. So we have the popular examples are sirolimus and paclitaxel. These are actually used in case of angioplasty. So in angioplasty, a bypass will be created, or where a stent is placed. It's also coated with a layer of drug so that the drug is slowly released into the circulation and produces its effect. So the stent is also my requirement of stent also is done, and the drug also is given in the form of stent itself so that continuously it is released. So drug-eluting stents are just metallic stents, a backbone which is covered with the polymer, and the drug is gradually released over 14 to 30 days, and it modifies the local healing response with the stented artery, within the stented artery. So I put a stent in one blocked artery. So the stent maintains the patency of the artery. It also helps in healing of the wound of that particular artery. So particularly in coronary angioplasty we use. Then we have something called targeted delivery. See, all this while I told you for headache, we give paracetamol orally, but it somehow relieves your headache. So you have joint pain, you take a tablet orally, but it relieves your joint pain. But for some conditions, say for example, you have a fungal infection of the liver. So either I have to give an oral tablet or an injection. So instead of this, now we have something called targeted delivery, where we inject medicine or drug directly into the liver or directly into any particular tissue that is required. That is called targeted delivery. So most commonly targeted delivery is particularly used for anti-cancer drugs, where we use monoclonal antibodies against the cancer cell antigens. Fine. So under this we have many examples, which is called Liposomes. Liposomes are one type of vehicles for targeted drug delivery. Liposomes are basically concentric spherical shaped shells of phospholipids. They have a shell of phospholipid inside which there is a free space in the watery medium into which the drugs are incorporated. So it's a shell of phospholipid. In the center, you have a space where you can incorporate the drug. So millions of such liposome particles will be incorporated with the drug, where you can directly inject into the tissue required. It could be liver, or it could be gallbladder, it could be spleen, whatever. So this is, as I mentioned, particularly used for anti-cancer drugs. And popular drugs used are doxorubicin, and antifungal drugs amphotericin B has been tried with this liposomal route. So anti-cancer is doxorubicin, where it is popularly called Doxil. That means doxorubicin liposomal preparation. And we have amphotericin B, which is called ambisome, which is amphotericin B liposomal preparation for antifungal. Say, for example, fungal infection of the brain, that is fungal encephalitis. It's not easy to treat. It's a very difficult thing. So I can try targeted delivery of amphotericin brain. That is called targeted delivery. I hope you got some idea about this targeted delivery. Insulin is being tried, but it's a very, very primitive stages of the trial. Then we have something called osmotic drug delivery systems, or gastrointestinal therapeutic systems, where the drug is delivered directly into the GIT. And examples under this, we have prazosin and nifedipine. Okay, it's also in the research phase. Then you have iontophoresis. Iontophoresis is using a charge, using a current. So galvanic current is applied on the skin, which allows penetration of drugs into the deeper tissues. That is called iontophoresis, which means either using a charge or using a current. So how do? We have anode iontophoresis and cathode iontophoresis. In anode iontophoresis, for compounds having positive charge, we use a negative current. For drugs having a negative charge, we use a positive current, so that the forces of repulsion will drive the drug into the deeper tissues. These are some of the targeted drug delivery systems. Okay, is that clear till here? Has it been clear till now? Am I audible? Any doubts till here? Okay, anode iontophoresis. See, iontophoresis is applying current to drive the drug into the deeper tissues. If it's a negative charged drug, we apply a positive current. If it's a positively charged drug, we apply negative current, so that the force of repulsion will drive the drug into the deeper tissues. That's it. It's very simple. Okay. Okay. So we'll just take a 5-minute break before we start this topic. Is that clear? Is that okay? Fine. Yeah, take a 5-minute break and come back. We shall start the class back. Are you all there? Can we start? Okay, next we'll go to the next concept here. It's a very simple concept which you have already read in biochemistry, something called chirality. You would have read chirality of molecules like glucose, fructose, etc. Now we see chirality of drugs, which means handedness. That means most commonly, most of the drugs that we use exist in 50 to 50 mixture of racemates. That means they have both left-handed and right-handed compounds. They're called stereoisomers. Basically, stereoisomer is a mirror image. Okay, but these two molecules, the left-handed one and the right-handed one, may differ in the properties or even adverse effect profile. Many times we combine the two so that the adverse effect of one is decreased by the other and any other features of one is helped by the other compound. Okay, nowadays what we've started doing is, in order to reduce the adverse effect profile of the drug, we have started using only one of the stereoisomer. It could be either a left-handed one or a right-handed one, or where we call it as R and S compounds. Okay, like for example, for atenolol, we have started using only S-atenolol. For salbutamol, we've started using R-salbutamol. Or for cetirizine, you all know that levocetirizine is a newer version which helps in reducing the sedation that is seen with cetirizine. Okay, so it's a lever compound. So that's all is chirality, which means handedness. Most commonly used drugs are available in both forms, but also we can use a single molecule in order to reduce the adverse effect profile. So coming to the next important chapter, pharmacokinetics. Okay, till now we only saw the most basics in general pharmacology. Now we come to the topic proper. Now we have two major branches here, what is called as pharmacokinetics and dynamics. Okay, now what is pharmacokinetics? Pharmacokinetics means movement of the drug, which means what is happening to the drug when it is moving through the body. That means what happens to the drug or what the body does to the drug is called pharmacokinetics. So what the body does to the drug is pharmacokinetics. What the drug does to the body is pharmacodynamics. So what happens to the drug is kinetics. What happens to the body is dynamics. Okay, you can remember with whatever way, in whatever way you want, but it's basically what the body does to the drug, which is pharmacokinetics. Now, under which we have four major branches called ADME, absorption, distribution, metabolism, and excretion. Clear? So we see the four different pathways of drug movement inside the body. How does it get absorbed? How does it get distributed to the particular tissues? So before excretion, it has to get metabolized. How will it get metabolized? And then how is it excreted through the body? Now coming to the first step, that is absorption. Absorption simply means whichever route you are giving the drug, by whichever route, till the time it enters systemic circulation is called absorption, which means movement of the drug from the site of administration till it reaches systemic circulation is called absorption. Clear? So it's mostly a passive diffusion. That means it just diffuses. It doesn't need any active transport majority of the times. But there are also drugs which require active transport or carrier-mediated transport or facilitated transport to push it from the site of administration to the systemic circulation. Okay, so absorption simply means whether you give orally or IM or rectal, it has to reach systemic circulation, that is the blood. So majority of the drugs are usually absorbed from upper part of small intestine. Say if this is for drugs given by oral route, it enters the stomach, then it goes into the intestine. So majority of the drugs are absorbed from upper part of small intestine. But there are also drugs which are directly absorbed from the stomach even before it reaches the intestine. For example, NSAIDs. For example, NSAIDs. That is why NSAIDs or analgesics, which you have been commonly using in your day-to-day practice, are known to produce incidence of gastritis. The incidence of gastritis due to NSAIDs is because of their gastric absorption. Is that clear? Then we also have other drugs like phenobarbital, that is a barbiturate, and even alcohol. Alcoholics will end up in severe gastritis because alcohol is absorbed from the stomach. We also have salicylates. So these are few drugs. Most commonly it is NSAIDs, which are absorbed directly from the stomach. Then we have, I told you, mostly drugs go into the circulation by passive diffusion. The drugs which require active transport, that means active means they need energy because they're going against the concentration gradient. If they're going towards concentration gradient, they don't need any energy. So there are drugs which go against the concentration gradient and they require energy in the form of ATP. And examples for that is levodopa and methyl dopa. So you can remember as L-dopa and M-dopa, popular examples. Then you have facilitated transport. Facilitated transport occurs along the concentration gradient. It doesn't need energy, but it requires a carrier to carry that. That is called facilitated. So it is being facilitated with the help of something. And popular example for this is 5-fluorouracil, which is an anti-cancer drug. If you don't understand about the drugs, don't worry. Once we do the systemic pharmacology, it will become clear for you. Okay, so this slide is just to show you if an MCQ appears. All drugs are absorbed by active transport except, or all drugs are absorbed by passive diffusion except, something like that. So active transport is L-dopa and M-dopa, and facilitated transport is 5-fluorouracil. Then I just told some transport proteins are required for absorption. So some of the transport proteins, some examples, you just need to know the names. We have something called SLC transporters. They're also called solute carrier transporters. I just told you for facilitated diffusion, we need a carrier. So that is, we have SLC transporter. Then we have P-glycoprotein. We have ATP binding cassette transporters. These are just the names of transport proteins which help in facilitated diffusion for certain drugs. We have organic anion transporting polypeptide and organic cationic transporter, OATP and OACT. So I repeat, SLC transporters, P-glycoprotein, ATP binding cassette transporters, organic anion transporters, and cation transporters. Fine, just know the names, and among which P-glycoprotein is the most important. So the next slide shows some general principles of absorption, which means for a drug to be absorbed, what all does it follow? It follows certain principles. So weak acids are better absorbed in acidic environment, which means weak acids, they're not strong acids, are better absorbed in acidic environment, and weak bases are better absorbed in basic environment. Remember this principle of absorption. It may not remain same for excretion. It's only for absorption. Weak acids are better absorbed in acidic environment and weak bases are better absorbed in basic environment. And for easy penetration or diffusion, that means for easy movement of the molecule from any site of administration to the blood circulation, the molecule should be unionized. So I hope you know the concept of ionization and unionization. So a molecule is better absorbed if it is unionized. A molecule is better excreted if it is ionized. Please remember this. Okay, so weak acids are better absorbed in acidic environment and weak bases in basic environment. Then for easy penetration or diffusion, a molecule should be unionized. These are the principles. Next, we go to the next concept in absorption, which is called bioavailability. Now, what is bioavailability? I told you absorption means from wherever it is going systemic circulation. But say, for example, I'm giving paracetamol 650. I'm giving Dolo 650 by oral route. Now, is the entire amount of the drug that is present in Dolo 650 reaching the circulation, or less of it is reaching systemic circulation, or what is the amount that is reaching systemic circulation is called bioavailability. That means amount of drug going into the systemic circulation is called bioavailability. Is it clear? Amount or fraction, which means when I give 650 mg of paracetamol, say for example, only 80% of it is going, rest of it is getting destroyed on its way to the circulation. It could be in the gastric stomach, or it could be in the walls of the intestine. It could be by portal circulation liver. Anyhow, so what is that amount of fraction? How much of it is reaching systemic circulation is called bioavailability. So each drug will have a different bioavailability. It could be 10%, it could be 50%, it could be 100%, it could be 80%. So usually for oral drugs, it is always less than 100%. And for IV drugs, because you are directly injecting into the circulation, there is no chance that it gets destroyed anywhere else. So for IV drugs, bioavailability is 100%. Okay. Say, for example, a drug has only 10% bioavailability. What is the point in giving? Isn't it? 90% is being destroyed. So at such, these are the certain factors where we don't prepare that particular drug by oral route at all. We always prefer by giving IV route or say sublingual or some other route. Fine. That is how we decide on different routes of drug administration depending on its properties. So it's the amount of drug going into the blood without metabolism. It is not undergoing any metabolism, that is by stomach wall or intestinal wall. Without any change, what is the amount that is reaching circulation? So it is a measure of rate and extent of drug absorption. So what is the rate at which it is getting absorbed? What is the extent to which it is absorbed? Is it 80% absorbed? Is it 100% absorbed or what? So it is denoted by the letter F. Bioavailability is denoted by F, which means fraction. It stands for fraction. So when the drug is administered IV, bioavailability is 100%, as I've already told you. But still there are drugs, even when given by IV route, it may not have 100% bioavailability. And the example for that is chloramphenicol. Chloramphenicol is an antibiotic. Even when given by IV, this is the only exception. Otherwise, most of the majority of the drugs have 100% bioavailability. And I told you oral, it is most of the times bioavailability is less. But there are some drugs which have 100% bioavailability even when given by oral route. These are the exceptions, which means they are not destroyed by stomach wall or intestinal wall or the liver. Examples for that is warfarin, clonidine, and levofloxacin. Okay, warfarin, clonidine, and levofloxacin. And how do we calculate or how do we check for bioavailability? We plot a graph where plasma concentration is plotted against time, which means at 0 hour, what is the plasma concentration? At 1 hour, what is the concentration of the drug? At 2 hours, what? So you get a graph. That is called area under curve, and that is a curve which denotes bioavailability of any particular drug. Is it clear? So we plot a graph. That's how I will know what amount of drug has reached the circulation, isn't it? Is it 80% or 90% or 100%? So that is called area under curve. And for any route, I use IV route as a reference because IV is 100. So if I have to calculate bioavailability by any route, say it is subcutaneous or IM route, I use IV route as a reference and I use this formula. Area under curve by oral route or subcutaneous or whatever route divided by area under curve by IV route into 100. That is the value that I get to find out the bioavailability of that particular drug given by that particular route. Okay, so is this concept understood by all of you? Have you understood all this? Okay, very good. So we'll move on. Now, I told you a drug may be absorbed 20% or 80%. What are the factors which determine this bioavailability? That means what are the factors which help you to tell 80% is getting absorbed or 50% is getting absorbed? Most important, there are many factors. One of the factors is food. So you all must be knowing, sometimes we tell the patient to take the drug with food, after food, before food, etc. So food can increase absorption of certain drugs. At the same time, food can decrease absorption of certain drugs. Okay, you should know the popular standard examples for this. Food can increase absorption of drugs like griseofulvin, nitrofurantoin, carbamazepine. Again, each one drug, if I go on describing, it will take time. Don't break your head too much. You will learn all this in systemic pharmacology. Clear? So anyways, griseofulvin is an antifungal drug. Nitrofurantoin is an antibiotic for urinary infections. Carbamazepine is an anti-epileptic drug. These are the drugs where food increases absorption, which means the absorption will be more, which means if you expect 80% to get absorbed, 90% will get absorbed. Food can decrease absorption of some drugs. Like for example, digoxin, azithromycin, phenytoin and tetracycline. So in this place, whatever effect you expect may not be produced because food is decreasing absorption of these drugs. Whereas food may not have any effect on this particular drug. That popular example is fluoroquinolones. Whenever the patient takes quinolones, food will not influence the absorption. Okay, these popular examples, please remember the effect of food with absorption. And then size of the tablet may be related to bioavailability. So you give more dose, more amount enters the circulation. And particle size is inversely proportional to. Smaller the particle size, faster is the bioavailability and more is the bioavailability. Greater the particle size, it has to get disintegrated, it has to get dissolved in the body fluids, then it has to go to circulation, so it may be less. So it is inversely proportional. Then physical state. So either it is lipid or water soluble. Better lipid solubility, better is the absorption. But this principle becomes opposite for excretion. Better water soluble, better is the excretion. Fine. And then you have nature of the dosage form. Like, see, some drugs we take in the form of syrup, some drugs you take in the form of tablet, etc. Tablet, if it's a solid preparation, it has to be broken down to smaller particles and it has to be dissolved. So directly if you give in the form of a liquid, it is faster and more. So nature of dosage form also decides the bioavailability. Then you have, yes, tell me. Physical state, which means either the drug is more lipid soluble or more water soluble. See, the better the lipid soluble, it can easily cross the membranes, whatever barriers, and it can reach the systemic circulation. So better lipid soluble, better is a bioavailability. But for excretion, it differs. Don't remember the same principle for excretion. For absorption, more lipid soluble, more absorption. For excretion, more water soluble, more excretion. That's what I meant. Okay. Is that clear? Whoever asked the question, did you understand? Okay. And the nature of dosage form we finished, and presence of other drugs. One drug can reduce absorption or increase the absorption of the other drug. In the next few topics, how one drug can influence the effect of other drug. And then pharmacogenetic factors, as we just discussed sometime before, genes can influence the effect of drugs in different individuals. And then disease states. For example, somebody has a renal failure, kidney failure. So that amount of drug is not getting excreted. So more remains in the blood. Okay, so more bioavailability. It's like that. So presence of any disease state can influence absorption. So these are some of the factors which can influence bioavailability, which bioavailability simply means absorption of any drug. Okay, so we'll go to the next concept, first pass metabolism. Now I just told you all drugs may not have 100% bioavailability. It differs from drug to drug. Why is it not 100%? Why is it not completely entering the systemic circulation? I just mentioned to you that some of it can get destroyed on its movement through the gastric wall or the intestinal wall. Particularly for oral, I mentioned, particularly for oral.
isn't it? Or by the portal circulation liver. That is called first pass metabolism. Okay, this is different from the metabolism that happens after distribution. So ADME, what we saw, that metabolism is completely different from this. That is proper metabolism, and this is first pass metabolism, which means before passing through the systemic circulation, what is the metabolism that is happening? The drug is mildly broken down before it reaches the circulation. That is called first pass metabolism. Is that clear? That means metabolism happening before it reaches the systemic circulation. So after it reaches systemic circulation, after it goes to the specific tissues, then it gets metabolized. That is metabolism proper. So where all first pass metabolism can happen, as I've already mentioned, it could be in the stomach wall or intestinal wall or liver, which is the most common place. Otherwise, for certain other drugs, it can be through the skin or through the lungs. When you give a drug through the lung before entry into the circulation, some of it can get destroyed by the lung. Clear? So, if I ask you the question, now tell me what is the relationship between first pass metabolism and bioavailability? It would be inversely proportional. So, more first pass metabolism, less drug is entering the circulation, less bioavailability. Less first pass metabolism, more drug entering circulation, more bioavailability. Fine. Is the concept of bioavailability understood? Okay. So some popular examples of drugs which undergo metabolism in the intestine. Levodopa. That is levodopa, which is a precursor of dopamine, undergoes first mass metabolism. And I told you these two are the most common places for first pass metabolism. And then you have liver. So liver, you can remember the mnemonic ABC, which includes alpha blockers, beta blockers, and calcium channel blockers. So these ABC drugs will undergo first pass metabolism in the liver. L-dopa will undergo metabolism in the first pass metabolism in the intestinal wall. And drugs with very high first pass metabolism, I was just mentioning to you, if a drug has very less bioavailability, there is no point giving by oral route. Fine. So these are the drugs which have very high first pass metabolism. For example, lignocaine. See, that is why we don't have oral lignocaine, because there's no point giving oral lignocaine because most of it gets destroyed. Very less enters the circulation. So we give lignocaine by every other route. Like we give topical, we give IV, we give for spinal anesthesia into the subarachnoid space, we give injectables into the tissues, like to produce anesthesia for the local site, but we never give oral. And morphine also is never given by oral route, it's only given by IV because of its very high first pass. Propranolol has high first pass, but it is available as an oral tablet, okay, because of other properties which we see in propranolol beta blocker chapter. And hydrocortisone. Hydrocortisone is the fastest acting steroid. It is never available as an oral preparation because of its very high first pass. It is only given by IV route. Clear? These are few examples: lignocaine, morphine, propranolol, and hydrocortisone. But this is exception. Though propranolol's first pass is less, it is available as oral drug. Okay, we'll see that. Then drugs with low first pass metabolism, like phenobarbital, which means most of it enters the circulation. Phenobarbital, which is a barbiturate. Then you have tolbutamide, you have theophylline, you have isosorbide mononitrate. Tolbutamide is a antidiabetic drug which is not used anymore. You have theophylline, which is a bronchial asthma drug, and you have isosorbide mononitrate, which is a nitrate which is used in the treatment of angina. Clear? So these are the standard examples for drugs which undergo metabolism in the intestine, in the liver, drugs with high first pass and low first pass. Next, coming to the concept, subtopic ion trapping among this first pass metabolism. Now, what is this ion trapping? See, when acidic drug, say you have given acidic drug, it comes in contact with acidic pH of the stomach. So normally what it should happen, it's an acidic drug. Acidic stomach is normally acidic. So normally there is no ionization, isn't it? Opposite charge only gets ionized. So it remains in the unionized state. Okay. So what did I tell for absorption? It better should be in the unionized state. And some drugs like aspirin, which is an acidic drug, it gets absorbed from the stomach itself. That I already told you, NSAIDs, without even reaching the intestine. So for absorption, what happens? It enters a gastric mucosal cell. So this acidic drug aspirin remained in the acidic gastric medium. It was unionized. But when it enters into the gastric parietal cell, there the pH is alkaline. Within the gastric parietal cell, the pH is alkaline. Here, this acidic drug will become ionized and it gets stored. That is called ion trapping, and this is the reason for the severe incidence of gastritis seen by aspirin. I hope it is understood. Aspirin acidic drug remains acidic in the gastric medium. It remains unionized, but it penetrates the gastric mucosal cell where it becomes ionized and it remains within the cell, which is called ion trapping, which is a reason for its high incidence of gastritis, damage to the gastric parietal cell. Have you all understood? Did you understand? Okay. See, aspirin is an acidic drug. In the it normally stomach is acidic. Of course, it remains unionized, isn't it? Acid in acid cannot get ionized, so it remains unionized. But this drug gets absorbed through the stomach and not through the intestine, so it penetrates the gastric mucosal cell. Inside the gastric mucosal cell, the pH is alkaline. So here the acidic drug in alkaline medium will become ionized, so it is stored in the gastric parietal cell. So it is there for a long time, which results in damage to the gastric parietal cell and gastric erosions, which is responsible for causing gastritis due to aspirin. Okay. And there are cases where to facilitate drug absorption by oral route, microfining of drug particles is done. That means we reduce the size of the particles to facilitate drug absorption. If I give huge particles, it will take long time to produce an effect. So we do microfining of drug particles. That is done for aspirin, cresofulvin, and spironolactone. And sometimes I don't want the effect to be faster. I want the effect to be slow. But particularly, I increase the particle size of the drug, which is seen for bifenium hydroxynaphthate. It's a drug which is given, antihelminthic drug, which is given for treatment of worms. So here I want the effect to be slow and long lasting. So I increase the particle size. Okay. So there are cases where you reduce the particle size also. There are cases where you increase the particle size also. So after seeing bioavailability, that's a concept called bioequivalence, which means bioequivalence. Now I told you oral drug can have 60%, IM drug can have 80%, whatever is the figure. Now I have many brands in the society. Like for paracetamol, I have Crocin, Calpol, Dolo 650, etc. whatever. Now all these brands have the same bioavailability because they have paracetamol. They are all paracetamol, isn't it? But I don't know whether the extent of absorption is 80% for all the three. That is called bioequivalence. So the rate and extent of bioavailability of the active ingredients in two formulations which are pharmaceutically equivalent, which means they're all paracetamol, but they're different brands. Do they have the same bioavailability is called bioequivalence. We carry out all these something called BA studies before bringing any drug into the market. Did you understand? Now I have a brand paracetamol which is believed. I believe Dolo 650. Now one more company wants to bring paracetamol. Now I use this as a reference to check the bioavailability of the newer drug. Is bioavailability of the newer drug same as Dolo 650? That is called bioequivalence. Clear? So BA-based studies are very important for drugs having narrow margin of safety, which means narrow margin of safety. These drugs are not very safe when even mild increase in dosage can result in toxicity. They are called drugs with narrow margin of safety. And during antimicrobial therapy failure, I have given an antibiotic. I don't know why there was a failure. Maybe because its bioavailability was less. Okay, I have given a proper antibiotic only, but it failed to produce an effect. Clear? These are few cases where we perform BA/BE studies. Before bringing out any new drug into the market, we do something called BA/BE studies. That's called bioavailability and bioequivalence. That's about absorption. Did you all understand? Any doubts you have? Did you understand the absorption part? Okay. Before going to distribution, we'll just take a small break and join for distribution. Is that clear? Okay, we'll take a short break and come back. We'll start with the distribution. Are you all there? Can I start with distribution? Are you all there? Can you hear me? Okay. So I already told you, after absorption, it gets distributed to different tissues. So it simply means spread of the drug to different tissues. Now, to understand, say, the drug from blood, it can go anywhere. So to understand the concept of distribution, we have developed one parameter so that it gives a value for us. Otherwise, it's not easy for me to describe where the drug is going to which. There are so many compartments, so many tissues in the body. Okay, so to prevent this confusion, we have developed a concept which is called apparent volume of distribution, which means it's an apparent value, it's not a true value, but for the ease of calculating, we have this formula. Now, what is it, apparent volume of distribution? It is that volume that would accommodate all the drug in the body if the concentration throughout was the same as in plasma. So imagine the concentration of the entire compartment is same like plasma. So what volume of the body will accommodate that amount of drug? That is called apparent volume of distribution. So for example, instead of different tissues, you have brain, you have pancreas, you have kidney, etc. Consider body as a single compartment. So what volume of the body will accommodate all the drug in the body if the concentration throughout the compartment was, you considered it as it was same in the plasma? That is called apparent volume of distribution. So this is just an arbitrary apparent value to make us our calculation easy. How much of the drug is getting distributed? Otherwise, I will not know how much of drug is getting distributed. Okay, so the formula for this is apparent volume of distribution is equal to the dose of the drug administered divided by plasma concentration. So dose of drug administered by IV route, we take it as reference value IV route. What dose of drug did I administer divided by plasma concentration gives me the figure for distribution. Now, why should I know this distribution? First of all, why should I know this amount of the drug got distributed? Anyways, I will not know otherwise. So I've given an apparent value, right? But why should I know? Now, what is the clinical importance? For example, if I know that a particular drug has high volume of distribution, which means it gets distributed to multiple tissues, then in case there is poisoning of this particular drug, it is not easy to remove this particular drug from the body. I only have to use dialysis. Okay, it has very high volume of distribution. It got distributed to multiple tissues, multiple compartments. Then it is not easy for me to remove this drug after poisoning. I only have to use hemodialysis. Even an antidote will not work for this. Okay, did you understand? So some examples of drugs which have very high volume of distribution and which require hemodialysis. I have given the mnemonic as BLAST. You can remember barbiturate, lithium, alcohol, salicylates, and theophylline. These are the drugs which have very high volume of distribution, and hemodialysis only helps. Okay, I cannot use any other mode of treatment if there is poisoning due to these drugs. I repeat the mnemonic: BLAST, barbiturate, lithium, alcohol, salicylates, and theophylline. Okay, then under distribution, we have another concept called redistribution. Redistribution means it is not that second time it is getting distributed. No, it is not like that. This phenomenon is seen with drugs with high lipid solubility. Say there are drugs you have given which are very high lipid soluble. First, what it does is, I told you, for a drug to be absorbed better, they have to be lipid soluble. Correct. So for a drug to for a lipid soluble drug, it gets absorbed very faster, but it goes to drug with very high blood flow. very good vascularity, which means, for example, brain, liver are highly vascular tissues. Most vascular is brain. So it first goes into the brain. Then what happens later? Less vascular but more bulky tissues will take up the drug, which means it will come out of the brain immediately and it will enter other tissues. This results in termination of action of certain drugs. That is called redistribution. Okay, highly lipid soluble drugs first enter tissues of high vascularity like brain, immediately they come out. That is why drugs like thiopentone, which is a general anesthetic, will act only for 5 minutes because it's highly lipid soluble. It enters the brain, and because of its high lipid solubility, it even comes out faster and goes and gets deposited in adipose tissue. What is the point of getting deposited in adipose tissue? It will not produce its general anesthetic effect. I want it to get deposited in the brain. Right, so this results in termination of drug action. That is called redistribution. The most and the best example for this is thiopentone, which is a general anesthetic. The other drug which also has this property of redistribution is diazepam. Okay, is this concept understood? Next, we'll go to tissue distribution. So I told you drugs can get distributed to different tissues. Now we have certain examples. Please give me 2 minutes. I'll just come back.
Sorry for the break. We will start again. Okay, can I start again? Okay, so we were talking about tissue distribution. To which tissues, which drugs most commonly get deposited? Okay, other than the site of action. Other than the site of action, it can also go and get deposited in different tissues by by producing adverse effects. Okay, for example, the drug which gets deposited in the brain is chlorpromazine. Chlorpromazine is an antipsychotic drug. As an adverse effect, it can get deposited in the brain. Okay, but most important, from MCQ point, what questions are asked for you is drugs which get deposited in the eye and produce disturbed vision. Okay, so amiodarone is a drug which is an actually anti-arrhythmic drug. You will not be studying that about that at all, but you just know amiodarone is an anti-arrhythmic drug. It gets deposited on the cornea, producing corneal microdeposits, bringing about corneal haziness and causing disturbed vision. And then digoxin. Digoxin is a drug which is used for CHF, which is an alkaloid. It can produce yellow vision. And you have chloroquine, which can produce blue vision. All this is disturbed visions. Please go through this properly because this is an MCQ. Then you have thyroidazine, which causes brown vision. Then ethambutol interferes with red-green color vision. So the patient will have difficulty in identifying red and green color. So these are some of the drugs which get deposited in the eye and causes disturbed vision. I repeat, digoxin yellow vision, chloroquine blue vision, thyroidazine brown vision, and ethambutol interferes with red-green color vision. Then you have drugs which get deposited in the heart itself. That is digoxin and emetin. So digoxin gets deposited both in the eye and the heart. Then you have skeletal muscle. Again, digoxin also gets deposited in the skeletal muscle, particularly in old patients. Okay, so in old patients, because the muscle mass is less and digoxin gets deposited in the muscle, we usually tend to reduce the dose of digoxin. So digoxin gets deposited in 3 tissues: heart, eye, and skeletal muscle. Eye is more important for you. Please go through that. Then we have certain barriers that you all know for a drug to get distributed, for a drug to go to a particular tissue. It has to cross through a barrier if a barrier is there. The most important and tough barrier you all know is blood-brain barrier. So for not every drug can easily pass through the blood-brain barrier to get deposited in the brain. Okay, because blood-brain barrier is the most strongest barrier. But yet, this barrier has certain deficiencies through which the drug can pass. Now, what are the deficiencies? You can remember the mnemonic S cap. You all would have read in physiology the barriers in blood-brain barrier, the blood-brain barrier deficiencies, right? So remember the mnemonic cap. You have CTZ, that is chemoreceptor trigger zone, which is there in the medulla oblongata. Then you have pineal body, P for P. Then A, you have both anterior hypothalamus and anterior and lateral commissures. So these are the 4 deficiencies in blood-brain barrier through which any molecular drug can pass through. I repeat, chemoreceptor trigger zone, anterior hypothalamus, anterior and lateral commissures, and pineal body. So drugs which do not cross the blood-brain barrier whatsoever, okay, are, you all know, the most popular one is dopamine. Dopamine does not cross through blood-brain barrier, hence we give in the form of levodopa. So levodopa crosses blood-brain barrier and then gets converted to dopamine. So treatment of Parkinsonism is not dopamine, but it is levodopa because dopamine does not cross through blood-brain barrier. Right. Other than that, you have molecules like streptomycin. Streptomycin does not cross blood-brain barrier. So we cannot give streptomycin for CNS tuberculosis, though it's an antitubercular drug. Then we have neostigmine. Neostigmine is a huge molecule. It's a quaternary compound. It's a big molecule. It cannot cross the blood-brain barrier. And domperidone also cannot cross through blood-brain barrier. So these are some of the drugs which cannot cross through blood-brain barrier. See, some drugs do not usually cross, but if there is inflammation of meninges where the meninges will become weak, then they can cross.
Okay, so in cases of infection, it can cross when given. But otherwise, normally if you give, it doesn't cross the blood-brain barrier. The example for that is penicillin. So if you give penicillin G in a otherwise normal individual, it will not cross blood-brain barrier. But if he has meningitis or encephalitis, penicillin G can pass through blood-brain barrier and produce its effect on the CNS. So that is about the toughest barrier, which is blood-brain barrier. But there's another barrier called blood-placental barrier, which is a very, very weak barrier. Any drug can pass through placenta and produce effects in the fetus. Hence, we try to avoid any drug in pregnancy unless and until indicated. Like, for example, supplements you can leave, folic acid, iron, calcium, vitamins we give. Other than that, any drug unnecessarily is avoided because every drug passes through placental barrier. But this also has exceptions. There are three molecules, atropine, insulin, and heparin, which do not cross through placental barrier. Hence, these are the drugs of choice in pregnancy. For example, if I want to give an anticholinergic drug in pregnancy, I can safely give atropine. If I want to give anti-diabetic drug in pregnancy, I cannot give any oral drug. Insulin is the drug of choice for diabetes in pregnancy. If I have to give anticoagulant, it is heparin, which is a drug of choice because it does not cross through placenta and does not produce any harmful effects. Whereas warfarin, if I give, warfarin will cause anomalies in the fetus because it causes placental barrier. I hope you have understood. These three are the drugs which do not cross through placental barrier. These three are the drugs which do not cross through placental barrier doesn't mean that every other drug, there's no say drug which is given in pregnancy at all. There are drugs which even if they cross, they are safe. Okay, like paracetamol, even if it crosses, it is safe. Nothing it does to the fetus. So there are certain safe drugs which can be given in pregnancy, but these are heavy molecules which do not cross through placental barrier. So what is the reason for this? See, normally pH of the placenta is 7.2, which is slightly on the acidic side. So these are also acidic drugs which remain unionized and hence cannot cross through the placenta. Okay, that's the answer for why these drugs do not cross through the placenta. Then we spoke about tissue distribution. Now, before going into the tissues, say from the blood, the drug is going into the tissues. Now, it is there in the blood, isn't it? Now, in what form it can be there in the blood? It can be in the bound form or it can be in the free form. It can bind to some proteins which is there in the blood, that is plasma proteins, or it can be in the free form, that is called plasma proteins. You have many types of plasma proteins, out of which most common ones are albumin and alpha-1 acid-glycoprotein. Acidic drugs bind to albumin and basic drugs bind to alpha-1 acid-glycoprotein. Okay, this is a standard. Now, acidic drugs examples: NSAIDs, barbiturates, benzodiazepines, penicillin, tetracycline. All these are acidic drugs. They will remain bind to albumin when they are in circulation. Now, what is the importance of this? Why should you know all these acidic drugs will bind to albumin? For example, there's a patient with liver disease. So what will happen to albumin levels in him? Albumin is synthesized in the liver. So when he has liver disease, albumin is not being synthesized in normal values. That means he has hypoalbuminemia. Now, if I give a drug which is supposed to bind to albumin, what happens? There is less amount of albumin. So there is less amount of binding of the drug to albumin. So there is more free form. It is a free form which is producing action and not the bound form. Once the free form is over, the bound form is slowly released from the free form. The free form is released slowly from the bound form. That's the concept. Now, if very less binds to albumin and more of it is there in the free form, there is result that there can be toxicity. So in that condition, we need to decrease the dose. That is the significance of knowing which drug binds to what. Have you understood this concept? Did you understand this? What happens in hypoalbuminemia? There can be toxicity, so please reduce the dose. See, if there is liver disease, there will be hypoalbuminemia because liver is the one which secretes albumin. Now, if I give a drug which is supposed to be binding to albumin, that drug is not binding to albumin because albumin is less. More of it will be in the free form instead of bound form. So, more free form, more toxicity. So, to reduce the toxicity, you have to reduce the dose. So if there is a patient with liver disease, reduce the dose of acidic drugs. That's a simple thing. Now, basic drugs will bind to alpha-1 acid glycoprotein, and there are conditions where alpha-1 acid glycoprotein can be increased. For example, myocardial infarction. Whenever a patient has heart attack, MI, alpha-1 acid glycoprotein will increase. So what you should do, almost whatever drug you give will be in the bind form. There will be very little for producing the effect. So you have to increase the dose of basic drugs. So in a liver patient, reduce the dose of acidic drugs. In a heart attack patient, increase the dose of basic drugs. It just says like that because alpha-1 acid glycoprotein will be more. Whatever basic drug you give, everything will go and bind to alpha-1 acid glycoprotein. There's very little free form to produce an effect. There is no effect at all. So we have to increase the dose. So some of the concepts. Now, as I've already told you, it is a free form which is there for action and not the bound form. Once the free form is over, the bound form slowly will release the drug from the plasma protein. So highly bound drugs have restriction to vascular compartment, which means highly plasma protein bound drugs. There are drugs which are highly plasma protein bound. They will remain more in the blood only because they have more binding to plasma protein. Plasma proteins are the ones which are in the plasma. So they have less volume of distribution to the tissues. So a drug which has high plasma protein binding will remain more in the blood and less in the tissues. Okay. So it is easier for us to remove this drug in case of toxicity. I told you high VD drugs, we only do hemodialysis and not anything else. Right. And and as I explained, only free form is available for action and not the bound form. Bound form will not produce action. It only is bound to the plasma protein. It is released slowly once the free form is over. So what is the other significance of knowing this plasma protein bound? If there's a drug which is highly plasma protein bound, which means a lot of it is bound to plasma protein, slowly it is releasing the free form, which means the drug becomes longer acting. So highly plasma protein bound means highly a longer duration of action drugs, and highly bound drugs show drug displacement reactions, which means there are drugs which are binding to two plasma proteins or the same plasma protein. One drug is already bound. When next drug is given, it will come and displace that particular drug from the plasma protein. So that drug free form increases, which may result in toxicity. Okay. One sec. Okay. So highly bound drugs have longer duration of action and they're prone for displacement reactions. So examples for highly plasma protein bound drugs. You have drugs like sulfonamides, methotrexate, indomethacin, and warfarin. Warfarin is the most important and commonly asked example among highly plasma protein bound drugs. Okay, and drugs which are zero bound, they don't bind to plasma proteins at all. They'll be just in the free form always, so they're more prone for developing toxicity. And in such cases, we need to be keep monitoring for their adverse effects. Example, ethosuximide and lithium, among which lithium is more important. Okay, lithium is 0% bound and warfarin is 100% bound. Okay, so I hope you understood the concept of plasma protein binding. There are proteins in the plasma to which the drug binds, and the bind form will not act. It's only the free form which will produce the effect. And slowly the bound form will release the drug once the free form is over. Then I just mentioned to you, highly plasma protein bound drugs can have displacement reactions, which means there's a drug which is already bound to plasma protein. You administer the second drug, which is also binding to the same plasma protein. It will come and displace the first drug so that the first drug's free form increases, which results in toxicity. For example, aspirin plus methotrexate. Now, the patient is on methotrexate for whom you give aspirin. Aspirin displaces methotrexate from the plasma protein. So what happens? Once it displaces, no bound form, only free form. So increased methotrexate levels, which results in toxicity. Similarly with warfarin and chloraldehyde. Chloraldehyde will displace warfarin. So more levels of warfarin free form. So more effect, more toxicity, which means what toxicity can happen? Warfarin is an anticoagulant, which is preventing the coagulation. So more of breakdown of coagulation will result in bleeding. So when you give chloraldehyde to a patient who's on warfarin, they both undergo displacement reactions, which may result in bleeding. That's about displacement reaction. Okay. So next we just have two important terms to know, affinity and specificity. Affinity just means action, which means the power with which it binds to the plasma protein, and specificity indicates safety, which means it is more specific. It is binding to one particular plasma protein only. Okay, these two terms you should know, affinity and specificity. Okay, so with this we complete distribution also. We go to the next step, metabolism or biotransformation. Okay, till here are things clear for you? Till here, is everything clear? Okay. Till what time you want me to take? Till what time you want me to continue? Please let me know. Are you all there? Just let me know till what time you want me to continue. Because it's a very tough topic. It's not that easy. You should be in a receptive mood to listen to this. Roughly, can you tell me till what time you want me to continue? Okay, we'll finish till 9:30 and we'll wind up. Okay, so we'll just briefly see about metabolism then. So metabolism, I told you we have finished absorption, distribution. We're coming to the metabolism. That means it's got distributed to tissues. It has produced its effect. Now it has to get excreted. So before it has to get excreted, it has to undergo certain changes. Like a drug which was lipid soluble, if it remains lipid soluble, it will not get excreted easily. I told you it has to be water soluble. So this is the process which converts a highly lipid soluble drug to water soluble in order to make it favorable for getting excreted. That's all is what is happening in metabolism, which means it is broken down to a form which is easily excreted. So it is chemical alteration of drug in the body. It is just altering the drug in the body, or it is inactivating it. So what's the purpose of this step? It helps in easy elimination of the drug. That's all. Okay. This step is making the drug favorable for elimination. So aim is to convert lipid soluble to lipid insoluble drug. I told you a drug is better absorbed if it is lipid soluble. A drug is better excreted if it is water soluble. So convert lipid soluble drug to water soluble drug and make it favorable for excretion. Now, which are the sites through which the drugs get excreted? Which are the sites through which the drugs get metabolized? Most common is liver. Liver is a site for metabolism. There are other sites, that is kidney, intestine, lungs, and plasma. Yeah, tell me. A drug is better absorbed if it is unionized. It will be better excreted if it is ionized. Okay, and that concept of ionization differs for different drugs. Don't make it uniform. Okay, I will tell you when it comes in excretion. Don't get confused now. Okay, so liver is a common site for metabolism. Other tissues are kidney, intestine, lungs, and plasma. There are drugs which do not undergo metabolism at all. They are directly excreted. Example for that is streptomycin, neostigmine, and mannitol. Okay, so there are three major processes which happens in metabolism. That means either the drug is inactivated, active drug is converted to inactive drug, or active drug is converted to active metabolite, or a prodrug which was inactive is converted to active metabolite. Okay, active drug to inactive drug, active drug to active metabolite, or inactive drug, that is prodrug, to active metabolite. Any of these three steps can happen in biotransformation. So I told you liver is the most common site for biotransformation, but very rare sites are even, I told you, kidney, intestine, lungs, and plasma. So the drugs which undergo metabolism in the lungs is prostaglandin. So examples for drugs which undergo metabolism, it is not excretion, through the lungs is prostaglandins. Now, what happens in biotransformation? There are two phases for any drug to undergo metabolism. Okay, we call it as phase 1 and phase 2. Now, phase 1 is called non-synthetic reaction, where there is no new product formed. But in phase 2, there's a new product formed after phase 2. So it is called a synthetic or a conjugation reaction. Phase 1 is simply conversion from one form of the molecule to one form of the drug to another. Which means, what is happening here? It can be oxidation, reduction, hydrolysis, or cyclization. Oxidation means addition of a molecule of oxygen or a mole of hydrogen. So you're not getting a new molecule, it's only changing the molecule. Reduction is addition of hydrogen or a mole of oxygen. Hydrolysis means breakdown of a molecule with the breakdown of a drug with the help of molecule of water. Use water, break down it. That's hydrolysis. And cyclization, convert a straight chain compound into ring compound. So these are few phase 1 reactions where no new product is formed. So they are called non-synthetic reactions. If it's phase 2, then the molecule, the drug first enters phase 1, undergoes some change, then it enters phase 2, where a new synthetic product is formed. So that's why it's called synthetic reaction. Now what happens in phase 2 is it combines with certain product, certain metabolite, and the drug becomes a part of that metabolite. Like for example, I'll tell you. So glucuronide conjugation, which means a drug called chloramphenicol undergoes glucuronide conjugation, so whereby it becomes chloramphenicol glucuronide, or there's a new compound which is formed after glucuronide conjugation of chloramphenicol. So similarly, every drug will produce a new compound after phase 2 metabolism. Then you have acetylation. Acetylation is quite important. Remember these examples of drugs. Remember the mnemonic ship for acetylation. Sulfonamides, hydrolysine, INH isoniazid, and para-amino-salicylic acid. Please remember this mnemonic. Acetylation example is ship, which means at least you have to remember isoniazid. We will see why in tuberculosis chapter. Isoniazid undergoes acetylation. Methylation, that means it adds on to a methyl group. There it was added on to acetyl group, like that. So adrenaline and histamine undergo methylation reactions. Then sulfation, they add on to a sulfate molecule, morphine. Glycine conjugation, they add on to a glycine molecule, aspirin. So aspirin undergoes glycine conjugation. Next, most important here is paracetamol. You should remember, paracetamol undergoes which type of phase 2 reaction? It is glutathione conjugation. Okay, so paracetamol is glutathione conjugation. Isoniazid is acetylation. Then you have ribonucleoside or nucleotide synthesis. For example, we have purine and pyrimidine metabolites. So I just told you, normally a drug finishes absorption, distribution, enters phase 1 metabolism, phase 2 metabolism. That's how in the normal phase goes. But only those drugs which undergo acetylation, there is first phase 2 and then we come across phase 1. Okay, is that understood? Okay, then I just mentioned to you about prodrug. I told you prodrug can be converted to an active drug. Now, what is exactly a prodrug? Prodrug is actually an inactive form of a drug which gets converted to active form in the body. Okay, so what are the advantages of prodrug? Why do we give this prodrug? They'll be more stable. They're not easily destroyed by after action of the drug. They're more stable. They have a better bioavailability because they're not broken down by first pass metabolism, and they may have less side effects or toxicity compared to the active drug. Okay, so if I want any of these benefits, I make a drug as prodrug so that after entering into the body, it gets converted into active drug. Okay, these are some of the examples. Morphine, active drug to active metabolite, these are the examples. Prodrug to active drug, you can see the last 3 examples. You already know levodopa is a prodrug which gets converted to dopamine after crossing the blood-brain barrier. Enalapril, which is an AC inhibitor, is also a prodrug which gets converted to enalaprilat. Then we have bacampicillin, which is actually the prodrug of ampicillin. You all would be using ampicillin left and right for your dental infections. So it's actually in the form of prodrug bacampicillin, after which it gets converted to ampicillin after entering the body. Okay, that's the concept of prodrug. Then there are drugs which are not prodrugs, which don't have the concept of prodrugs at all. They have to be given by active form. One of the common examples is paracetamol. So you have pyrimethamine, trimethoprim, paracetamol, carbamazepine, and cotrimoxazole. Okay, so that's about drugs which are not progress. And coming to brief about bonds between the drugs that is formed. Okay, normally there's covalent bond which is formed between phase 1 metabolite and phase 2 endogenous product. That means phase 1 product and phase 2 product, normally covalent bond is formed, and it's the strongest bond between the drug and the receptor. This is a question. The strongest known bond is covalent bond, and the weakest is van der Waals bond. But the most common bond that you come across is electrostatic bond. Please remember this. Covalent bond is the strongest, weakest is van der Waals bond, and most common is electrostatic bond. Sorry. Now coming to in metabolism only, there's some concept called how is metabolism happening? You may think of now, how is this breakdown of a drug, or how is this conversion of drug from prodrug or active drug to inactive happening? There are 2 ways by which it can happen. One is enzymatic and one is non-enzymatic. Now, what are these enzymes? Where are these enzymes coming from? There are certain enzymes which are called cytochrome P enzymes, which are released from the smooth endoplasmic reticulum of every cell, which are responsible for this biotransformation or conversion of the drug. There are also drugs without the help of enzymes also they're getting converted. That is called non-enzymatic elimination. So we'll finish off non-enzymatic first. So without the help of the cytochrome P enzymes, which are located in smooth endoplasmic reticulum, a drug can undergo metabolism or conversion. That is called Hoffman's elimination. This is a very, very important MCQ. Hoffman's elimination is non-enzymatic degradation or biotransformation of a molecule. Under which examples you have atracurium, cisatracurium, phenoxybenzamine, and haloperidol. Most important example is atracurium and cisatracurium. Okay, now that's all for Hoffman's elimination. Now enzymatic is the most common seen for 99.9% of the drugs, which means there are certain enzymes which are released from the smooth endoplasmic reticulum, which either increase the effect of these enzymes or decrease the effect of these enzymes. Okay, so this cytochrome P, if it increases the effect of enzymes, it increases metabolism. That means it is inducing metabolism. They are called inducers. If the cytochrome P enzymes, will inhibit the effect of a particular drug, they are called inhibitors. Very simple. We have enzymatic, non-enzymatic. Under enzymatic, we have enzyme inducers and enzyme inhibitors, which means there are drugs which will induce the synthesis of these enzymes more, so that more metabolism happens. There are drugs which will inhibit the synthesis of these enzymes so that less metabolism happens. Okay, did you understand the concept of inducers and inhibitors? Did you understand the concept of inducers and inhibitors? Okay, now we'll see examples. For enzymes, inducers and inhibitors. Now I just told you the drugs which will induce the synthesis of more enzymes, so more metabolism happens, because the metabolism is because of these enzymes. Drugs which inhibit the synthesis of these enzymes, so less metabolism happens. Now, popular example, I have given you mnemonic. Remember the mnemonics for inducers and inhibitors, most common ones. Okay, there may be many others also, but if you remember this, it's more than sufficient. Now, mnemonic for inducers is car gas. Remember it as car gas. That means cigarette smoking. So even an individual who's smoking, if you give any other drug, that cigarette will induce the metabolism of the second drug. So can anybody tell me what is the consequence of the second drug? If this smoking will induce the metabolism, what will happen to the second drug? Induce metabolism means faster breakdown. So what will happen? Can anybody tell me? What will happen if inducers are given with some other drugs? That's my question. Very good. Bioavailability will decrease. So effect of the drug will decrease. It's very good. Okay. So if you give inducers with some other, that means if a cigarette smoker is taking a second drug, the effect of second drug will be less, which means either you have to stop smoking or stop inducer or increase the dose of the second drug. Okay. Similarly, alcohol. Alcohol acts as an inducer. So when you give any drug in an alcoholic, the effect of that second drug will be less. Okay, you have other examples like rifampicin, R for rifampicin, anti-tubercular drug. Rifampicin is a popular enzyme inducer. Then you have G for glucocorticoids and griseofulvin. Then all anti-epileptics except valproate. So all anti-epileptics, if you see phenobarbital, phenytoin, carbamazepine, all are inducers except valproate. So that is for A. Then next S you have spironolactone and sulfonamide. So all these are standard and enzyme inducer drugs. I repeat, cigarette smoking, alcohol, rifampicin, griseofulvin, glucocorticoids. That means steroids are also inducers. Then all anti-epileptics except valproate, spironolactone and sulfonamide. Please remember this mnemonic, which includes majority of the inducer drugs. Clinically, what we ask. So usually question will revolve around an alcoholic was given a second drug. So what happens to the effect of this drug? Either have to increase the dose or what? Okay, that's how question will be. Or a patient rifampicin anti-tubercular drug, she was given a second drug, so that effect of second drug came down, something like that. So if you say example here, so this patient was on warfarin. He was also put on rifampicin. So rifampicin is an enzyme inducer, which means it will induce the metabolism of warfarin, which means metabolism is faster, which means effect of warfarin is less, which means warfarin has to act as an anticoagulant. It is not acting as an anticoagulant, which means the clot is still there. Did you understand till here? Rifampicin and warfarin. Similarly, when a patient is on rifampicin, OCPs, oral contraceptive pills, and you put her on rifampicin, rifampicin will induce a metabolism of oral contraceptives, which means its metabolism is faster, which means its effect is less in the body, which means OCPs, what it was supposed to act, is not acting, which means contraceptive failure, which means there are chances that she can become pregnant even with OCPs. Okay, that is the concept of inducers. Have you understood these two examples?
Very good. Now coming to inhibitors. Inhibitors opposite effect. They will inhibit the metabolism of the second drug. So the drug is not broken down, which means the drug is there in the body for a long time, which means it can result in toxicity. Here it is less effect, there it is more effect, so toxicity. So example for inhibitors, you have the mnemonic phase dip. F is not for any drug, F is for Flagyl. Flagyl is a popular brand name for metronidazole, so I've taken that. Phase dip, A for amiodarone, C for ciprofloxacin, cimetidine, and clarithromycin, E for erythromycin. Many times questions will revolve around erythromycin because it's a very popular enzyme inhibitor. Then you have dextropropoxyphene, then you have INH, isoniazid. So rifampicin was an inducer, isoniazid is an inhibitor. Then you have oral contraceptive pills, P for pills. Remember this mnemonic. So here what is happening? The second drug will produce toxicity. Say for example, you combine erythromycin with cisapride or terfenadine. They are both cardiotoxic. So what happens? More toxicity on the heart. They can have cardiac arrhythmias. Okay. Okay, next is elimination. But till biotransformation, have you understood? Please answer me. Have you understood till biotransformation?